Good morning, everyone. This is Manos Pyrlakis from Minneapolis Heart Institute, and it's a great pleasure to introduce Dr. Imre Ungi from the University of Szeged in Szeged, Hungary. Dr. Ungi is one of the world-class leaders in CTO intervention, and he has very kindly agreed to present today's co-blessed coronary intervention webcast, which focuses on challenges with treating CTOs that have big side branches at the proximal and distal cap, an area that is very commonly encountered in everyday practice. So we're very excited to have Dr. Ungi present it. Again, Imre, welcome, and thank you so much for presenting this webcast.
Hello, Manos. Thank you for your kind invitation to this outstanding program, to this webcast presentation. Warm welcome to all of the audience, and I can tell you that it's a great privilege to me to be a part of this initiation. Today I would like to speak shortly about the challenges which are created by side branches during CTO revascularization. Actually, we know from the hybrid strategy that several morphological features distinct which strategy should be followed during the procedure. Although the presence or absence of side branches are not mentioned in the global chart of the hybrid strategy, but in a very recent publication from the group of Professor Pyrlakis, it's mentioned that the poorly defined proximal cap favors a primary retrograde approach, and we know that the ambiguity of the proximal cap frequently comes in flash occlusions, that it's difficult to decide where is the proximal cap related to the origin of the side branch. The other statement in this publication is that subintimal crossing may result in side branch occlusion in cases with a significant bifurcation at the distal cap. So both the proximal and the distal cap may create difficulties and challenges during the procedure. Just the occlusions of a coronary vessel, usually not started at a branching point of the coronary tree. The high shear stress usually protects the branches from an abrupt occlusion. So this is the typical cartoon of a young occlusion. However, during some weeks or months, due to the turbulent flow in the proximal and the distal stump and some stasis in these stumps, may grow the occlusion by a positional part of the thrombus. And the typical image of an old CTO is like on this right side cartoon. So there is a flash occlusion at the proximal branch, and typically there is a concave distal cap from below. Sooner or later, all the occlusions will grow, will increase in length to the neighboring side branches. So practically we can say that chronic total occlusions and bifurcations go hand in hand. Why is it a problem for the interventional cardiologist doing a CTO procedure? As we already mentioned, it's difficult to identify the proximal cap in case of a flash occlusion. difficult to puncture this hard proximal cap, especially if the angle between the wire and the proximal cap is shallow. And usually the wire is prone to get into the subintimal space at the distal cap. There are some clinical data and several evidence in the literature that the side branch, the presence of a side branch, is a significant predictor of the technical failure. Of course, there are strategies during CTO PCI with big side branches at the proximal or the distal cap, which can overcome this problem and this difficulty. The first, which is well known, that the proximal cap can be better identified by IVUS than by angiography, especially if the beta angle is low, so there is a shallow angle between the branches. The next one is an old technique, the open sesame technique, which is typical in the case when the wire gets into the side branch, not in the main branch. And for facilitation to enter into the main branch through the proximal cap, we do a balloon dilation at the proximal main branch through to the side branch. This balloon dilation will modify the proximal cap, modify the morphology of the entrance into the main branch, and with the second wire we can, or with repositioning of the first wire, we can get into the distal main branch. More and more use of the dual lumen microcatheters is generally in CTO revascularization, but especially if there is an important side branch in the CTO or around the CTO. I don't want to speak too much on these catheters because recently Freddy Galassi had a presentation on this platform on them. And of course, the retrograde approach, so the side branch is an important predictor why we should choose a retrograde approach with the CTOs and side branches. So with 3 cases, I would like to demonstrate the problems, the difficulties, and the potential complications caused by side branches at CTO revascularization. Our first case is actually it's not a really challenging case. At least the angiographic assessment of this patient seemed not to be very challenging. He is a 74-year-old male patient with typical risk factors. And this patient arrived the last year in our cath lab with a resting angina, and the coronary angiography revealed critical stenosis in the mid-LAD and CTO of the right coronary artery, which was a distal CTO. The echo revealed viable inferior wall of the left ventricle with preserved left ventricular ejection fraction. After stenting the LAD, the resting angina disappeared, but still, before the admission to the index procedure, the CTO revascularization, he still had effort angina, which limited his life, the normal activity of his life. Actually, I don't know whether the movies can be seen on your
You can see them very nicely. It looks perfect.
Okay, thank you. So it looks that there is a very distal chronic occlusion of the right coronary artery. It's a diffuse disease, the right coronary. And actually, there is a retrograde filling of the PD branch from the LAD. Because it seemed not to be very challenging from the antegrade side, we considered to do an antegrade, to follow an antegrade approach, and also because the part of the collaterals from the LAD was already covered by stents. So we started an antegrade wiring with a fine cross catheter, and with a Fielder XT, we could get the just next to the cap of the occlusion at the crux of the right coronary artery. So we tried to find a true lumen at the distal cap with the Fielder XT, which went as it looks on the right angio in the subintimal space of the PD branch. So we changed the wire. It's
so this is not
actually
dual cross. It's a fine cross microcatheter, right? The one we're using here. You're not using a dual lumen for this particular case.
Actually, we will use, but at this phase of the procedure, we started with a fine cross catheter. So still there is a fine cross inside, and due to the subintimal passage of the Fielder, we changed to Gaia first, and finally with the Gaia we got into the posterolateral branch, not in the PD. When we checked with retrograde angio the position of the Gaia, it was in the true lumen of the posterolateral branch, but as it is demonstrated on this enlarged magnified still image, the entry into the posterolateral branch was subintimal. So there was a 1 or 2 millimeter subintimal part of the Gaia wire. So at this phase, we changed the fine cross to a dual lumen catheter. It was a twin pass, and tried to find the true entry, the true lumen entry of the posterolateral branch. Unfortunately, it was not successful. We repeatedly got into the subintima of the PL and the PD as well. So at this phase,
sometimes people just accept one branch and they say, well, maybe we sacrifice one branch. But this was a fairly large posterior descending artery. So your thoughts are, do you always try to get both branches on a distal bifurcation? Or if it's a small branch, you may sometimes just accept losing one of the branches to get the bigger one?
It's an excellent question. Thank you, Manos. Actually, if the branch is small, actually here, for me, it seemed that both branches are big. Of course, the PD is really important. For me, it depends on two considerations: the size of the branch and the supplied area, of course, as you mentioned, and the other, if there is a very good collateral to one of the branches. Sometimes, if it's not possible to preserve both of the branches, I give up the well collateralized, the better collateralized branch. It's sometimes typical that from the circumflex to the PL there is a side branch size epicardial collateral. You certainly met this situation several times. So sometimes I think we can give up preserving both. both of the branches.
Perfect. And I think that's what most people do.
Sorry?
No, I agree. I think that's what most people do as well.
Yeah, thank you. So finally, here I wanted to preserve both of the branches. So we removed the twin pass and inserted a Sion black into the over the wire lumen of the twin pass, and at 1 inch, so still at the soft part of the distal end of the Sion black, we created a hairpin, and this unit of the microcatheter and the hairpin Sion black introduced again on the wire in the posterolateral branch. On the left still image, we can see in the distal part of the posterolateral the bent second wire. Maybe it's unfortunately it's not the best quality, but on the right angio, it can be seen that we already pulled back the twin pass, and with some pulling and rotating manipulation, we could find the true lumen of the PD branch with the second wire, which is in the OTW lumen of the twin pass. So we crossed the occlusion with the twin pass and the hairpin wire, and we could get the PD true lumen. After some gentle predilation, it seemed that there is no big dissection, no contrast residual. So we finally stented the vessel crossover from the distal right coronary to the PD, and we kept the gelled wire in the PL. After kissing balloon inflation, we got a nice bifurcation with one stent, so with a provisional T-stent technique. There is a diffuse disease in the proximal part, but at this procedure we did not put more stents. Finally we decided to do it depending on ischemia in the future. So that was the final result, and I think that in this case one of the key of the success was that from the distal true lumen of one of the branches, we could engage the other true lumen, the true lumen of the other branch, with a hairpin wire and with a double lumen catheter.
Perfect. And then, Imre, one quick question. So did you try first to wire through the twin pass without the hairpin, or you tried right away with the hairpin?
Yes, we tried to do it with the conventional, with the regular use. So I created a normal band. Probably, I don't know why was a failure with this way. Probably I started with the subintimal space, or it stuck in a plug. But finally it was not successful. So that was why I felt safer to start from the distal direction, not from proximal.
Perfect. No, this is wonderful. I think quite often many people will try first just to wire through the side branch, and you're right, this is a little less traumatic because you avoid any potential dissections on the origin of the branch, like the PDA in this case. So I think that's a very good point, that maybe starting with a hairpin immediately increases your likelihood for success.
Yeah, I think it's an extremely important point, also because we have one case when we already dissected with several attempts of antegrade wiring in the main branch. And when we finally try to do, I have no image documentation on this patient, but finally when we finally turn to this hairpin approach, also the hairpin wire went into the subintimal space. So if we started too late, it can be a failure.
Perfect. No, thank you. That's a wonderful case.
Thank you, Manos. And I would like to mention a little bit a similar case. This is the second case, but it has some maybe some more complexity in this situation. So actually, this gentleman is a 61-year-old male patient with a CCS 3-grade angina. In another hospital, ostial LAD occlusion was revealed, and they did an antegrade approach, an antegrade attempt, which was a failure. So they referred to our center for a retrograde recanalization of the LAD. Actually, I completely how to say disregarded the retrograde approach in this patient because these telephone cord-like epicardial collaterals, which were the only collaterals from the right, altogether 4 or 5 very, very tortuous collaterals came. And the reason why these collaterals were the only supply of the LAD, that also there was a distal PD CTO on the right coronary as well. So there was no option to get blood from through the septas to the LAD. So I think that this patient is not suitable at all to retrograde. So we repeated an antegrade approach as a second attempt. On the right angio from the caudal view, it looks that the occlusion is almost a flush occlusion at the big circumflex artery. And during the procedure, when preparing the reference images, I realized that it's the occlusion is not a single occlusion, but there is a double occlusion of the proximal and the mid LAD. So I prepared a small animation to understand better the structure of this anatomy. This red line is the first proximal cap, which is followed by the first occlusion in the proximal LAD. And at the distal cap of the proximal occlusion, a short open island of the LAD follows with some branches coming from and to this small island. One of them is the big diagonal branch at the distal cap. There are, in yellow, there are the collaterals, the tortuous collaterals coming from the right to this small island. And there is also a big septal branch. After this small island, there is a second occlusion, and then the runoff of the distal LAD. So it was quite a complex situation. We started, I'm sorry.
No, I agree. It looks fairly complicated. A lot of ambiguity in the proximal cap, the big diagonal you don't want to lose. That's clearly a... So you didn't think it was the CTO, it was the vessel there, it was just a collateral from the proximal cap all the way to the distal?
Yeah.
Perfect.
So actually, that is the situation. We started. Of course, the only suitable approach as a first intention was the antegrade wire escalation because the big branches at the distal cap, big branch of the distal cap. So we started again with the fine cross and first punctured the proximal cap with the confianza Pro 12, then de-escalated first to a Fielder XT, but the Fielder XT got into deeply into the subintimal space, so we changed to a Gaia second wire in the fine cross catheter. On the right side angiogram, it looks that with some manipulation with the Gaia second, we got into the true lumen. Unfortunately, not that of the main branch, but the side branch to the diagonal branch. So after that, the strategy was the same. Then in the first patient with the right coronary, we took the dual lumen catheter. It was again a twin pass, and started with the regular use of the twin pass. This wiring and to find the small island of the LED. Unfortunately, it failed, and as you called our attention, I didn't want to repeat it too much because I was afraid to dissect this part of the LED. So again, we did a hairpin. We removed the twin pass from the vessel and introduced a Sion black into the over the wire lumen in the way which is demonstrated on this cartoon. On the next fluoro image, it looks then we crossed with this stuff, with this unit of the twin pass and the hairpin wire through the occlusion into the true lumen of the diagonal, and then first removing the twin pass and then pulling back the Sion black. It got into the small island of the LED, or actually not in the main branch, because it was a very short segment, but actually it went into one of the collaterals coming from the right coronary. So that was the situation after using this hairpin and twin pass. And it was, of course, it was very far from the final solution. At that point, we removed the twin pass and reloaded the fine cross into the small island of the LED. And with this help of the fine cross, we changed first the broken Sion black to Pilot 200, and with the Pilot 200 was positioned in a more stable branch, actually in the septal branch. So on the right angio, we can see the Gaia in the actually it's not the Gaia, it was already changed, but the Pilot in the septal branch. After that, removed again the fine cross and reloaded the twin pass on the Pilot. So now the distal port of the over the wire lumen of the twin pass was already in the short island of the LED, and as it looks on the right angio, with actually with an ultimate 3 wire, it was easy to cross the distal occlusion and to get into the runoff of the LED. I don't know whether these steps of the procedure can be understood, because
it was not hairpin, right? This one you just cut the microcatheter, the twin pass into the septal, and then you just wired straight with the wire from the over the wire lumen. Is that correct?
Yeah, that's true. So the monorail lumen was switched from the diagonal wire to the septal wire, and we used again the over the wire lumen for crossing the distal CTO of the LAD. So after these manipulations, it was we could remove already the septal wire. We did actually, because there was a very short subintimal part in the diagonal branch. So for case of safety, we did a low pressure kissing dilation in the LAD and the diagonal branch. We could not detect any significant dissection in the diagonal branch. There was TIMI3 flow. So again, we decided to do a provisional T stenting, and finally, with one long stent, we could cover both the occlusions of the LAD and in the big diagonal TIMI3 flow was at on the final angio.
And Imre, one quick question on this. So is the provisional working in cases like this where you have a side branch at the proximal cap? Do you find that provisional stenting works? Because some people have concerns that you have dissection in the branch and you might lose it if you do provisional. But it looks like in both cases so far, things worked out pretty well. What is your experience on that?
It's again a very good and important question. I think by the formal logics, these kind of procedures must be finished with a crash stent, with a mini crash. Because this is the only way when you can protect both of the branches. And the plan B for stenting for us was indeed crash stenting. But when after this low pressure predilation of the bifurcation, we realized that there is no contrast staining and there is a TIMI3 flow. We decided to use the provisional T, which statistically promise a better long-term result. I think that because it's not really reasonable. Why we didn't occlude the side branch if there was a subintimal part? I think that it was a short and a shallow passage of the wire in the subintimal space. So probably we disrupted the intima in that small segment, and there was no big space in the subintima which would have occluded the side branch. Actually, for a long-term result, maybe an restenosis at the ostium of the side branch can be, but for an acute result and a subacute result, it proved to be okay.
Perfect.
So that was actually these two cases have common learning points for me. So the big side branch at the distal cup is a challenge, of course, and the regular use of a dual lumen microcatheter is a more and more popular device for getting the distal true lumen when we are already in the side branch. But if there is a reverse rise of the side branch, or as in these cases, the reentry was a little bit distal to the bifurcation, it's now possible to get back into the other branch. And in these cases, combining the double lumen catheter, the hairpin wire, can be a safe and efficient key of the solution. Actually, my third case is a different one. In the first two cases, I tried to demonstrate which challenges and which problem can be created by the distal big side branch. This complication case try to make a demonstration of the potential troubles by a big proximal branch and how to resolve this problem. Again, a gentleman is the patient, 59-year-old, with several typical risk factors: dyslipidemia, diabetes, obesity, and hypertension. And he had a remote inferior myocardial infarction, but the inferior segment by echocardiography proved to be viable. But in the the very distal segments of the anterior septum and the apex was akinetic. Actually, he had CCS4 angina, and recently he had some syncope episodes. Once ventricular tachycardia could be demonstrated after this kind of syncope, so it was an ICD implantation was planned, but the EP guys required revascularization before the implantation of the defibrillator. On the dipyridamole echocardiography, there was an interceptal transient ischemia. After introduction of the clinical scenario, I would like to demonstrate the angiographic situation with this still image. So he is he has a left dominant coronary tree with some stenosis in the LAD. There is a proximal and then a mid-part stenosis, and there is a CTO at the distal part of the LAD, but as I mentioned, the apex proved not to be viable. That is the point of the circumflex CTO. This is the dominant circumflex. I'm sorry that this atrial branch just is overlapping position, but I could not get a better one. And this is the situation. At the mouse pointer, you can see the distal segment of the dominant circumflex and the distal cap of the occlusion. Actually, here is the proximal cap of the occlusion. So it's a flash occlusion at the rise of a big marginal branch. And as you can see, there is a faint supply of the distal circumflex through the septal collaterals coming from the diseased LAD. I decided to use an antegrade recanalization attempt of the flash occlusion of the distal circumflex because of the disease of the LAD. So I didn't want to do a retrograde. And just to identify the proximal cap of the occlusion, we did an IVUS from the proximal circ to the marginal branch. At the red line, we could identify the ostium of the marginal branch, and on the IVUS, it was clear that there is the proximal cap of the occlusion. So we started the puncturing the cap with the Confianza Pro 12 through a fine cross catheter, and actually we could puncture in the true lumen the proximal cap, but repeatedly the Confianza slipped off the proximal cap and jumped into the marginal branch, despite the well visibility through the IVUS. The next phase was the complication. This repeated jump into the marginal branch with the tapered stiff wire created an occlusive dissection of the obtuse marginal branch, which was a really desperating situation because this gentleman has a diseased LAD with a distal occlusion of the LAD, a non-dominant right coronary. The best and the most important branch was this marginal, probably, but we occluded it. So
just pain or as the changes, as the segment changes, or?
Yeah, there was severe angina and ST depression in the chest leads, and also it was not frankly not a cardiogenic shock, but a significant decrease of the blood pressure. So it was a really hot situation. That the only way was to stent this abruptly occluded marginal branch. I don't know whether you agree with this decision.
No, absolutely. I mean, the patient is unstable. I mean, the priority wants to make sure the patient gets stabilized more than anything else. So I completely agree with you.
Yeah. Actually, the other option would have been emergency surgery, but the patient was a very poor surgical candidate, so we decided to stent this marginal. So after that, the question came whether to stop it here or to continue. First, I wanted to stop, but realizing that he has one open vessel practically only, I decided to do a short attempt for the retrograde. So after a temporary dilation, balloon dilation of the LAD lesions and putting a safety wire into the LAD, I could find the connection between the LAD and the PD with the Sion wire through the first big septal. It looks on the right angiogram that the Sion, the tip of the Sion, is already in the distal part of the circumflex, and the microcatheter is still in the septal. On the right angiogram, the fine cross is already just in front of the distal cap in the distal circ, and the tip injection shows us the morphology of the distal cap and the occlusion. Here, with several wires, attempted crossing the occlusion. Actually, crossing the occlusion was not really difficult, but to cross the hard proximal cap and the stent was very challenging. So we finally created some subintimal channels out of the stent with wires, which was Retrograde and Confianza. And finally, we decided to put in the IVUS again next to the proximal cap of the the occlusion, and with the IVUS guidance, we continued the attempts to get into the lumen of the stent. I hope that, yeah. So on this IVUS image, it looks sometimes at 3 or 4 o'clock that the wire is still out of the stent. I think that you can see this appearance. Now there is the wire at 3 o'clock. Finally, after several attempts, with the guidance of the IVUS, we could enter into the true lumen, across the cell of the stent at the proximal cap, and got with the wire into the guiding catheter. It was an 8 French IVU4 guiding catheter. It was really difficult to get with the fine cross into the guiding catheter because we could not use a tapping balloon, and at that time I had no experience with the ping pong technique. Probably the ping pong technique would have been easier, but finally we could manage the situation. And when we were in the guiding catheter, we could change the confianza to an RG3. After antegrade dilation of the proximal cap and the occlusion, we transformed the previously implanted stent to a culotte stenting, and after high pressure inflation of the culotte stent, we did a kissing balloon inflation, then a pot, and after that we stented the proximal regions of the LED as well, because although the apex was not viable and we didn't want to open the LED, the distal part of the LED, but there were some septal and diagonal branches coming from the LED. So for the better revascularization, finally we did the LED as well. So on the right angio, we can see the final result of this procedure, after which, I'm sorry, the patient had a good clinical follow-up.
Imre, can I ask you, that was actually phenomenal, salvaging the bifurcation. Did you have difficulty advancing the retrograde microcatheter through the stent? Because actually I had a similar case recently where I got the microcatheter getting stuck on the stent. How was it easy in this particular case getting the retrograde microcatheter through the stent?
Again, a very important and a real good question. Actually, it was very difficult, especially at the I arrange it to see. I don't know. So it was crossing with the microcatheter of the proximal cap, and to advance the microcatheter in the stent. It was very difficult. As I mentioned, we could not use a trapping balloon in the same guiding catheter, and I did not dare to change the confianza to another wire. But to be true, the stiffness of the confianza helped us a little. But it was really, really difficult. So I think that in this case, a ping pong guiding and the trapping of the wire would have been better strategy.
Yeah, I think another alternative, I think George Sianos just actually had a case like this, is he put a guideliner, a smaller guideliner inside the guide and did the trapping of the retrograde wire inside the guideliner instead of doing it inside the main guide. So then this way he could trap, advance the retrograde microcatheter without, having the issue with the single guide catheter and affecting the other part of the wire. So it's another way to do it, but I agree with you. I think it's a very challenging. Going through a stent can be a problem, but of course you didn't have any choice here. The patient is unstable; he needed a stent anyway.
Yeah. So you are completely right. Yes, it's a good idea. I think that in this 8 French guiding catheter, maybe with a 6 French guideliner, it can be done. Because the fine cross is less than 1 millimeter. So maybe there is room enough for a 6 French guideliner and a fine cross in the same guiding.
Perfect. Well, thank you very much. I think these were 3 wonderful cases, actually, that illustrate the challenges of dealing with bifurcations and how to manage both the antegrade bifurcation as well as the distal cup bifurcation. So excellent tips and tricks. Imre, thank you so much for an excellent presentation.
Thank you, Manos. Thank you. It was a really exceptional opportunity for me to demonstrate our CTO practice, and it was my privilege to be a part of this outstanding program.
Great. Thank you so much again. And just to thank again the Dallas VIUS Corporation for organizing this, as well as Terumo and Abbott Vascular for providing support. So thank you very much, Imre, and thank to all of you participating in the webcast.
Thank you. Goodbye, Manos.
Thank you. Bye-bye.